Hey there, how are you? Definitely wanted to talk today about something that we get quite a bit of questions on. Now, it's a very common thing, and no, it's not very common. I don't know how common is it. I'll start over. Yeah. Okay. Yeah. Hey there, let's talk about the difference between an annular tear and a disc protrusion or bulge, okay? So you may hear these terms when you go to the doctor, when you get your MRI, when you get some scans done. They may say all of them. It may say like 4-5 has a bulge, 5-1 has an annular tear with a protrusion, right? Yep. So let's talk about what are those things, because those words can be scary, and it's important for you to understand what that means and what the likelihood of those diagnoses are. And then let's talk about what we would do as far as a kind of an entry level or some movements that we would start with if you had that diagnosis, all right?
So an annular tear or an annular fissure and a disc bulge or prolapse or herniation, they're kind of related in a way. One kind of like leads to the other. So if we're looking at a disc here, this would be the front side, this would be the back side here. You've got a ring of like cartilage that is all intermingled in different layers. And we can start to get cracks in those inner layers where you can see like this little line here where it's pressing out into those outer layers of the disc. That's more of like a disc annular tear or annular fissure where it comes out to the side and starts to get into those outer layers. It's not bulging yet, but it's close.
So this is the annular layer right here, that
Perfect.
outside, very crossed. So you might get a little bit of, like you said, a little crack or a little fissure in there where it can start allowing the integrity of that dam that holds the nucleus in is now lost because there's an actual tear to that annular wall.
And if that tear becomes significant enough, it can actually start to bulge that outer layer of the disc out. Or
the annular wall could even be gone.
Yeah, the annular wall can be gone and actually
escape.
Full-on herniation, which would be where it exceeds outside of that outer ring of the disc there. So that's the difference. They're very similar in nature. They present very similarly, but at the end of the day, it's just different stages of the disc injury.
Typically, it depends on where they are, right? So some may have like a central annular tear.
Yeah.
Some could be more off to one side, more off to one side. Now, if the annular wall is staying in, its integrity is sound, but a little piece of this nucleus, right, the jelly part or the part that's movable, starts to bulge into that annular wall, that also causes pain. Remember, there are nerve endings in this outer third.
Yep.
This outer third has nerve endings. This inner 2/3 does not have any nerve endings. So this can move around and you won't feel it. But as soon as it starts butting up against or bulging, kind of pushing on that annular wall, that's going to hurt. It's going to cause a lot of centralized pain, maybe just to the center right of the back or just the center left, or the neck, just to the center right, center left. Now, if the integrity of that dam that holds that in, like we talked about, is compromised somehow with a hole or a tear, that is much more likely to allow that material to escape, and then a bulge becomes a herniation. It changes,
Yep.
right? Or a sequestration or a extrusion, or there's different terms for it, but that's how they're related.
So Chris also made a very good point there about how only that outer third of the layer is innervated. That's the only part that has pain or can sense pain signals. This is why that pain often seemingly comes out of nowhere, right? All you did was bend over and pick something off the ground, or you bend over to brush your teeth, whatever it is, and all of a sudden that pain is there.
Or wake up. Or
The issue has been a long time coming on. It's just now manifesting as a full-blown symptoms.
It finally pushed far enough to hit those nerve endings.
Yeah.
Yeah.
And then I think with the other question
That also can just explain that people can truly, the pain can be from discogenic pain.
It almost always
Meaning it originates from that spot, even if it doesn't show very much on a scan. If it's just hitting that outer third, if it's just pushing up against it a little bit, even if it's not showing a large bulge, it can still be quite painful.
Yeah.
And some of the very big, large herniations that just just spill out into the thing can cause a lateral shift where you got your hips to the side, but they may also heal a little bit faster because the body recognizes that huge foreign material and sends all kinds of positive and healing cells there to eat that up and kind of shrink it down.
Yeah. So that's kind of the description of an annular tear versus a disc bulge or herniation.
Yep.
I think the second part of that question that we read was related to some lower level exercises that you can do when recovering from this.
What would someone do if they were diagnosed with, hey, I have back pain, I have leg pain, they say I have an annular tear, and there's a protrusion of that disc material, and let's just say it's irritating a nerve root in my neck, it's causing me down the arm, or in this case, let's say it's a back into a leg.
Yeah, so there's a lot of fear and other concerns that might come with this. So
You don't want to make it worse. Number one thing, you
No.
do not want to make it worse. We understand that.
if you have the opportunity to work with a professional to help guide you through this, this would be the exact scenario where this would be extremely valuable to you because they can help guide you on your specific body, what you can handle, what you can tolerate, and kind of guide you on different load levels and things there. But for a basic low-level routine, we kind of wrote something up here that we can work with.
And the reason, the reason we chose like prone, we chose prone on elbows first, or lying prone. That just means you lie on your stomach, or partly on your elbows. The reason would be, and let me just say, I think that's still, I can see it. Yep, we can see it still there. So the reason would be, when Jake was demonstrating that herniation or that annular tear, it's much more likely that it's going to be very flexion intolerant, meaning if you bend or sit, it's going to put pressure on the front side. I'm going to just switch these in my hand here. And it's more likely to put pressure on the front side of that disc, right? So if you're bending and you're putting pressure on the front side of this, you're likely to push more of it in the way, which is why sitting and bending hurt, and rising up, it's hard. But then once you're up walking around, generally, it's better. Not for everybody, but most people that have a tear, it's in the back, and so bending forward pushes more of that material through that hole, through that tear. So we would start here, just to see. It may not be for everybody. We understand that. No exercise is 100% like, universal for everyone. But I would start with some prone or prone on elbows, and depending on how that affected, right, it's cause and effect. It's mechanical cause and effect. It's not just do this, just because someone says to do it. What do you feel while you do it? So in this case, if Jake had right-sided pain into the leg, maybe even into the calf, if he goes here and pauses for just a bit, does it bring the pain up out of the calf and centralize it to the lower back and to the hip or buttock? Then we would say, that we definitely want to keep doing that. And if that were the case, then Jake go flat, and then we'd go plus then we'd actually work into it. Now what's going to happen more than likely is it's going to pinch, and it's going to hurt right there. That pain is not something that's a negative or a red light. If it feels like it increases the pain, even if it shoots it down a little bit, but then when Jake comes back down flat, he's like, within a few seconds, no, it feels no worse. It calms right back down. That's when you got to continue to work into. That's not a red light pain to increase a central pain or even produce a bit of pain for a brief, like a few seconds. But then as soon as he's done, it comes back up. Because what typically will happen is he'll actually get a benefit the more he does, but if you stop after the first one because it pinches in the low back, you'll never get to the point where it actually becomes beneficial.
Yeah, always test and retest.
And then the next one we do, so after that one, that's a big one because we want to see what the result was, right? So I mean, if it does benefit and it's working the right way, then we move on to the next ones. Then we move on to some dead bug, keeping the spine in neutral, because again we want to avoid too much flexion. Some bird dog, again keeping the spine mostly neutral, not having too much flexion or too much extension. And then some assisted squats. So here's would be so that we come over to the side here. Here would be where you could use your body weight. I'm gonna just move you over just a little bit, Jakey. There you go. So this is even less than body weight because your arms are going to help you come up. So squatting is not wrong. Someone say, you should never squat or deadlift. Well, getting up from a chair is a squat. So it's a functional movement. You got to be able to do it. But if even just body weight bothers you, then use your arms, hang on to something, and allow that to help. And then the last one we're going to be just a little bit of a slouch over correct. So that's the last one on the bottom here, slouch over correct. Because sitting tends to bother people a lot. We want to make sure we can understand that if we sit slouched and we have a posterior tilt, it may feel better temporarily, or even for him, he probably will lean over to his left because he's like, it hurts so bad on my right. I want to open it up. I want to give it space. It might feel better temporarily, but long term, if he sits there, it's going to be worse in the leg, and then when he stands, he's going to be stuck. So what we want to try to do is work into a little bit of a slouch, kind of feel what the end range is. We don't want to be there. Then go all the way tall and overcorrect and really arch. That's too far. But then back off that about 15, 20%, and that's that spine neutral you want to try to sit in for as long as you can. But even just using that slouch overcorrect back and forth just helps increase some of the blood flow and some of the nutrients to those tissues. Remember, the discs themselves don't get really none. They don't get arterial blood flow to them. They need their nutrition through movement and loading and back and forth. They don't get blood flow on their own, and that's why it feels stiff to sit for too long. So that would be our.
Hopefully you guys get some good information, good value out of that. If you have further questions, holler at us. But yeah, these are some good low-level points to start at that are pretty safe and not likely to irritate you.
Yeah, but even these, if you feel like, just remember the red, like red and green lights.
Yeah.
If it starts to bring the pain up the leg and your mechanics are like, oh, I'm kind of moving a little better, then keep going. Yeah. If for whatever reason it's not right for you, and it may not be right for you because of the timing or the load or the end range or even the direction, then okay, that's not right for you. You got to stop. If it's worse than the leg, that's a red light.
Yep.
So,
Yeah.
okay,
Awesome.
thanks.
Thanks.